neurologist coming from Turkey. They have a specialized center just to work on SUDEP, just to screen people with epilepsy and try to predict who are susceptible to have the sudden death and to work on preventive measures. So status epilepticus and suicide, whether it is unintentional injury or it is intentional suicide. These are the most important factors that make people with epilepsy have higher mortality rates. So when we talk about suicidal behavior in general, not in epilepsy patients, it has been found that it's related to a number of factors. Most important, when people have chronic, severe physical disease, whatever, name it. And when they have psychiatric problems, namely affective disorders and anxiety, people with borderline personality and some other personality disorders, and with substance abuse. And then when they analyzed, I know, I'm sure you know it better than me because this is part of psychiatry, when they analyzed the suicidal behavior, they found that it ranged from an idea to a suicide. And they categorized it into 4 in increasing severity and risk from just having a suicidal idea, having suicidal idea with a plan, then unplanned suicide attempt and planned suicide attempt. And they studied all these in different categories, and they found some risk factors for people to move from just have an idea to a higher level. And these are mainly psychosocial. Lack of support from family or friends, social and psychological issues, problems, whatever. I mean, my son who is an engineer, and he called me last night and he said he has a friend in a different city in Canada, and he had to spend, to cut it short, he said, I could not finish my homework. I said, why? He said, I spent 3 hours on the phone because a friend of mine called me from Calgary and he's suicidal. And I'm not professional. I had to chat with him for 3 hours just to make him give it up. And all because he lost his job and there was some problem. So psychosocial factors are very important precipitants of the shift or getting higher on the ladder of suicidality from idea to financial problems and lack of contact with clinical providers, especially in the West, especially in America and Canada, because they live in distant places. It's not just like our structures in the cities. That's one. Second, because of the system, you have to go through the GP or family physician unless you go to the ER. Lifetime prevalence of these 3. Just you fix the light in a very nice way. Can you do it? Okay. So ideation 13%, plan 3.5 or 3.9, 24, and attempt 4.6. And the ideators with a plan, of course, you would agree that they have more rate of attempting suicide compared to people who have only ideas. When they did cumulative probabilities, that's the statistics, they found that transition from an idea to a plan 34%, from a plan to attempt 72%, and 26% the patient can jump from an idea to an unplanned attempt when he's so desperate. However, 43% of attempts were unplanned, so the plan is not necessary. On the other hand, self-injurious behavior is also considered among the suicidal behavior. It's a risk factor for suicidal attempts, and I'm sure you all are familiar with people with borderline personalities and how the self-injurious behavior can end up with an attempted suicide. So the rates were found to be 55 to 80% of these people with self-injurious behavior, they will be engaged in a suicide attempt later. Among people with epilepsy, the injurious behavior, not necessarily to injure themselves, but willful non-compliance with medications, they will have more seizures, or involvement in risky activities, swimming and climbing, and know that they are not allowed to do that. And you know too that non-fatal self-injury is more among females, while the completed suicide is more among men. So, a few words about suicidal ideas and suicidal attempt. Suicidal ideas lead to increased risk of suicidal behavior and community-based struggle. And it's highest among homeless people, because we don't have many local studies more in the West. So homeless men and women, they have a rate up to 63%. They did a 12-year follow-up community sample, and they found that people with suicidal ideation at their baseline, they are more likely to attempt suicide later. And it has been noticed clearly that suicidal ideation and suicidality are very much related to psychiatric or physical illness. And the majority of suicides, when you go to the literature, they will tell you that the fatal outcome is a complication of psychiatric disorders. And the rates is 60 to 80%. People, when they commit suicide, they had some psychiatric problems. And namely, mood disorders at the time of death. So there is higher risk of attempt as long as the patient has ideation. And that's why we all would be alarmed when a patient mentions suicidal ideas, and we go through extensive inquiry to assess the risk of suicidality. Young people are a special category in epilepsy and suicide because they have higher rates. Adolescents, they have noticed that, and they tried to study it, why younger people with epilepsy, they have higher rates. And they found that because they already have higher rates of depression. And because this period is the most critical period in our life, and usually it's associated with changes, change of school, joining university, change of friends, moving to a different city, moving to a different, but they try to monitor what are other factors, and they found that knowing somebody who completed or attempted suicide has an effect. The low financial status, legal and social problems, lack of social support and employment. For suicidal attempts, also you share me that it's the most important predictor of future suicidality. That's why it has the highest score when you assess, and it's the most important predictor. Risk factors not for ideation, for suicidal attempt, is when you have the ideation, when you have a plan, when you have previous suicide attempt, for positive family history of suicide or psychiatric disorders, recent loss, and hopelessness. Moving to people with epilepsy, they have higher rates of all of these compared to the general population, suicidal ideation and behavior. And completed suicide is an important factor contributing why they have higher mortality rates compared to the general population. And when they studied extensively the rates of suicide among people with epilepsy compared to the general population, they found it to be almost 10 times the rate among general population, comparing 11% to 1.1 to 1.2. But then later, more extensive, wider studies, they found that this is too high, and they agreed upon, actually, I could find more than 10 or 12 papers talking about that. The agreed upon rate now is that it is 5 times higher among people with epilepsy compared to the 1.2, 1.4% among general population. Yet, if people have temporal lobe epilepsy, the rate would be 25 times higher. And even when they compare people with epilepsy with people with other chronic neurological disorders, they found that the rate of epilepsy is higher, 20% compared to 7%. Still higher than the general population, but it's almost 3 times the other people with neurological disorders. And this relationship between epilepsy and suicidality is quite complex. So many authors, they would suggest that epilepsy increases the risk for both, for psychiatric illness on one side and suicidal behavior on the other side. And there are some papers suggesting that it's a bidirectional relationship, because having attempted suicide with all its consequences, whether it was by drug overdose and how much that would affect the brain, or by suffocation, or wherever, it might cause some hypoxemia or metabolic changes in the brain, and increase the probability of having more epileptic seizures. And for the intentional medicational poisoning, this was a beautiful, well-designed study. I cited this one because it was impressive. That they found that People with epilepsy, they have 3 times higher rate of death by intentional medication poisoning. And the most common were opioid painkillers and, unfortunately, psychotropic medications. So, generally speaking, what are the risk factors for suicidal behavior in people with all neurological diseases? We have mentioned many of them. I mean, psychiatric comorbidities, social isolation, cognitive impairment have been found to be a highly important factor. And we are talking about causality. You know that. We are doing observational studies and trying to find correlation between certain factors, but these are all speculations and predictions. Moderate physical disability, recent loss, personal, occupational, financial, of course, past history of psychiatric illness, past history of suicidal behavior, substance abuse, and some personality disorders like borderline. Okay, when we go to people with epilepsy, because they are peculiar in their disease, in addition to the before mentioned factors, temporal lobe epilepsy, early onset of epilepsy. I believe you all know that early onset of epilepsy is a bad prognostic factor because it will be more resistant to treatment and it will be associated with more complications and sequelae. Very severe epilepsy, that is resistant to treatment or intractable, interectal and post-ictal psychopathology, especially the intermittent dysphoric disorder and psychosis, whether psychosis is interictal or it's post-ictal. As we have mentioned, cognitive impairment, personality change, and anti-epileptic medication is an added factor. So I will just 1 or 2 slides on the main factor. When we say psychiatric comorbidity, it's also almost agreed upon that suicide among people with epilepsy, it's not just of a psychosocial problem per se. It has significant relationship with interictal and post-ictal psychopathology. That's the observation. But still, they are just like other people. When they are very much distressed, when they are under a lot of psychosocial stress, they might impulsively attempt suicide. So they have increased risk of suicide associated with psychiatric illness. And as I mentioned, major depression is the most common, then followed by both bipolar disorder, substance abuse, and psychosis, and you add to it the personality disorders. And depression, which is the most important, most common psychiatric comorbidity among people with suicide, in epilepsy it is reached up to 50% plus. So the current literature, they stress that the risk of suicide in epilepsy is primarily associated with an intense depressive symptoms in the interphase. They have that, and that might be because they studied extensively people who attempted suicide and others, what did they have, what were their mood state. And the interictal dysphoric disorder was quite common, and it's a disorder special for epilepsy, this term, where there are depressive episodes with suicidal ideation, and it's more common with people with mesial temporal lobe sclerosis or mesial temporal lobe epilepsy. Depressive mood, it has been found to be common on people with interictal psychosis. They have interictal psychosis and they go into a severe depressive mood and they move higher in the ladder to attempt suicide. And post-ictal psychosis also was associated with increased risk of suicide, more with temporal lobe epilepsy. I'm sorry the topic is a bit depressive. We are talking about epilepsy on one side and suicide on the other side. I'm sorry for that, but it's important. Majority of studies, they agree that suicide in epilepsy almost exclusively happens because they have psychiatric illness, mainly depression. Yet, in 2011, this gentleman did an extensive survey, and he found that 1/3 of patients with epilepsy with suicidal behavior were euthymic, or they had only mild or subclinical depressive symptoms. And this brings them back to the general population motivations when they go to the. For adolescents with epilepsy, the high rates of suicide were also studied extensively, and they found it's probably related to the early onset of epilepsy, depression, because it's more common among adolescents, and unfortunately, because depression and other mental health problems among these people, they are underdiagnosed. they are missed, they are dismissed, and we consider the adolescent, this is part of adolescence. This is not part of adolescence. If he is reporting depressive symptoms, we have to study it extensively because he might be depressed and it's not part of the identity formation during life. So they need special care and attention. For severity of epilepsy, as I've mentioned, the postulate is that suicidal behavior is more common in people with severe epilepsy. And in chronic epilepsy, it's 20 to 25%. While they found, when they studied in a high group of patients, large group, that even seizure-free patients with epilepsy, yes, they have lower rates than people who are intractable to treatment, but still they have higher rates than the general population. Even it's reported in people who were recently, they were seizure-free.